I'm going to discuss about the tricuspid valve and the right ventricle in particular. Right ventricle was known for quite some time, and but still, I think we kind of ignored it. And why the right ventricle was always left out, I don't know. But that's why I think my talk on right ventricle functions and its importance and significance in dilated cardiomyopathy. First place, I want to, kind of awaken you. Why bother about right ventricle? It's a small ventricle just contracting for the pulmonary circulation. The botheration started when we have a patient of a pulmonary hypertension. The right ventricle functions were very, very important predictors for. So back to the RV functions in pulmonary artery hypertension. They decide prognosis. In fact, we on the guideline also we shown that there is a significant increase in mortality if the RV functions are not good versus if the RV functions are fine. That is heart failure survival, right? So if you have a heart failure and the RV functions are bad, that's not a good news. In reduced ejection fraction, if you have an RV dysfunction, look at the mortality figure versus ejection fraction of RV of 40% versus ejection fraction of 20%. It actually doubles. And that's not enough. I mean, that's again in TAPSI in patients with reduced heart failure. You just do a simple technique, TAPSI, it tells you the prognosis in that patient. Preserved ejection fraction, again the same story. The right ventricle functions are a very, very important prognostic marker for the future interventions. Even in myocarditis, you see if the RV is also involved, that's a bad news. So why have we been ignoring the elephant in the room? Let me tell you, there are now studies showing the patients, those who show improvement in the reduced ejection fraction, the patient, those who are on ARNI, those who show improvement of the functions and mortality, morbidity, have improvement in RV functions as well. So we have documented RV function improvement also with current congestive heart failure treatment. Is the RV different? Yes, RV is different. RV is kind of, if you see from the side, it's kind of a triangle. RV is wraps around the heart, and RV is just behind the sternum, makes it difficult to visualize on echocardiography because bone prevents a very good view of the right ventricle. The contraction is very different. See, the contraction of LV is like the normal contraction. RV contraction is like a peristalsis. The conus and the infundibulum contracts a few milliseconds later than the inflow and the body of the right ventricle. So that's the difference between the left and the right ventricular contraction. Left ventricle contributes to contraction of the right ventricle. You see it here, longitudinal contraction is the major contraction of the right ventricle. The circumferential contraction, which is called billowing effect, is again a major contributor. The interventricular septum, which bulges into the right ventricle during systole, contributes about 20% of the ejection fraction of the right ventricle. Circumferential contraction of the outflow also plays an important role. Second difference is the pressure. Right ventricle is Sharif, it is mild, it is weak. All those pressure manipulation on the right ventricle weigh very high. If you have a right ventricle pressure which is increased from 10 to 20, the ejection fraction or the pumping capacity drops drastically with that maneuver only. So that doesn't happen with left ventricle, which is strong. So anything small change in the right ventricle makes a lot of things. Okay, so that's why whenever we're going to assess the right ventricle functions, okay, we must keep in mind the loading conditions, so preload and afterload, because they are going to make a hell of a difference in RV functions than they would have made a difference to the LV functions, because LV itself is very strong. So where do we assess right ventricular functions? We make an assessment in a right heart failure, pulmonary hypertension. I think to cut the figure, in all patients, those who have a cardiac issue or a problem. You may not do it in a normal person, but whosoever has a problem, I think the RV function should be assessed. And how do we measure? M mode, 2D, Doppler. I think I'll cover all in the next couple of slides. My timer is running little faster than usual. I think I've wasted a couple of minutes. So please give me 2 minutes more. So recommendation for cardiac chamber, and we know that we need to use RV focused view. That is, you go to the apex, move little lateral, and probe is angled a little more towards the medially or towards the right shoulder, and that's where you see RV as an apex and RV as a predominant ventricle. All those calculation measurements, TAPC, everything is going to be done on RV focused view. Okay, and thickness is measured on a subcostal view. That's the best way to do it. And TAPC, yeah, TAPC is a very, very simple technique of movement of the excursion of the tricuspid annulus. TAPC gives you the amplitude of movement of the tricuspid annulus. And who moves tricuspid annulus? Tricuspid valve muscle. It pulls it towards the apex, right? And the second thing is, once you have a problem, an S wave of the annulus. S wave tells you what? The velocity, the speed with which the annulus moves. The speed which the annulus moves is S wave on a annulus, and the amplitude is TAPC. But the issue is that if you have the LV which pulls the apex of the right ventricle, or there is a severe tricuspid regurgitation, right, the TAPC and S waves are going to become more prominent. Okay. So that's why TAPC has practically no correlation with the right ventricular ejection fraction, but TAPC is simple to use, easy to use. That's why we continue to have faith with our friend TAPC. For the measurement, again, you have to be very careful. When you're in a 4-chamber view, you should not be moving direct anteriorly. If you're seeing the RV focused view, you're seeing the aorta along with, that means you are not in the right plane. Okay, so right plane you need to see, and this is how you take various measurements there. Okay, these are the upper limit of the measurements of the right ventricle. Okay, so now fractional change is you planimetry the right ventricle, leaving out the papillary muscles, leaving out the trabeculations, and then you do it in systole and diastole. This is fractional area change. Okay, we move, and then you take an S wave of, you have a pointer? Okay, the S wave on the tricuspid annulus, which again is used as a RV systolic function marker. GLS is something which is very, very important. We can do a global longitudinal strain of an RV, again an RV focused view, and that we can get either the free wall or the total RV. Total RV includes interventricular septum as well as the free wall. The free wall, which is more important. So I think I'll keep skipping because of the buzzer, but please give me 2 minutes more if that is allowed.
I think what we'll do is we'll give him 2 minutes plus 5 minutes more, because 5 minutes he wasted requesting for 2 minutes.
Okay, fine.
We have enough and more time. Two people
All
have
right.
not come.
So right ventricular ejection fraction by a particular software, because this is doesn't confine to a particular geometry, we can have the ejection fraction, and that ejection fraction really correlates well with the cardiac MRI, which I think is a gold standard as of today for right ventricular ejection fraction. So what do the parameters do? Now the longitudinal parameters, they make TAPC and the Doppler, and others are longitudinal plus contribution of the global functions, right? So if you want to bench upon, I would prefer using RV free wall strain. TAPC and S wave are have fallacies, but all these are preload and dependent. So these are the various RV functions. Okay, I think I'll skip this. And now you see this case 1, which has an RV function which is reduced, and you see the case 2 with RV functions are preserved. LV function is bad in both the situations, and you can tell the first gentleman is going to have more problems in future. And to the treatment, the patients, those who have an RV dysfunction in their paradigm study, showed that they had a poor outcome and they had a lower blood pressure to begin with when this hernia was started. Now look at the RV functions. To you, I think it looks good. Okay, then this is the LV function which is bad. Again, the RV functions actually look good. There is a caveat. This is not a good view because you see the aorta. This is little anteriorly placed position. You do a TAPC, and with the TAPC you find that the TAPC is more than 16. It is okay. You are happy with the TAPC, but when you do the global longitudinal strain, you see the GLS is borderline. It's not absolutely. More than 20 is normal, less than 15 is very bad. So it's borderline. That's another patient I'm going to show you. The RV functions look good, and this is RV focused view. This is what I wanted to tell you. This is RV. It's looking really good, and you do GLS on that. The global longitudinal strain is fine, so we are happy. This RV function is fine. The GLS of left atrial is also reasonable. Okay, so all 3 chambers are fine. I am happy there. But in this patient, there's another patient, I'm not really very happy. LV functions are bad. LV functions are bad. Look at the LA. RV is moving. Look at the LA functions. LA is hardly moving. Okay, so and if we do a global longitudinal strain of LV, it is bad. But if you do longitudinal strain of RV, it is okay. Do a longitudinal strain of left atrium, is pathetic. I think, sir, you can read it. It's somewhere around 3%. Okay. So LA again is very, very important chamber for assessment of the predictability of mortality in future. So you can, in the same patient, we had a mild to moderate MR at a pressure of about 90 millimeter of mercury. Look at the pressure of the mitral regurgitation, which clearly indicates a very elevated left atrial pressures, and E to E prime, E wave and A wave ratio more than 2 again tells you the same story, that LA is bad. Recently, this is the data which is coming. We have tried to find out in dilated cardiomyopathy which are the parameters from the AI we can detect which would predict an outcome. They have 3 main categories. One category is that where there is a mild involvement of both the ventricle. Second category is the category where there is a lot of fibrosis in the left ventricle, and this category belongs to diabetes, and it's a very high incidence of ventricular tachycardia. In all 3 categories, ventricular tachycardia only happened in this category. The third category had high mortality, which is LV and RV, both are involved, but ventricular tachycardia wasn't as much, but there was a problem of heart failure admissions and mortality. So we are learning more and more about the right ventricle functions in left ventricle diseases. So we need both left ventricle is strong, we know, but we need functions of right ventricle and left atrium also in patients with dilated cardiomyopathy. Thank you very much.